Esteemed listeners, welcome to Dentist's Coffee Time.
It's great to be back. Ready for another deep dive into what's really changing the game in our field.
Today, we are definitely doing a critical deep dive.
Yeah.
We're looking at the very definition of beauty in dental aesthetics. It's a topic that, it really blends art, anatomy, and some incredibly advanced technology.
And we're going to explore how that fusion is just fundamentally changing clinical practice and really predictability.
Exactly. We'll start by unpacking the foundational aesthetic rules. The core vertical and horizontal lines that define a harmonious smile and face. These are principles that have been understood for centuries.
The classics.
The classics. But the real mission of this deep dive is to show you how revolutionary digital smart design software now takes these ancient rules and integrates them with advanced 3D scanning technology.
And the result is you can create precisely measurable and predictable aesthetic outcomes.
Long before any clinical work even starts, this is really the secret weapon for anyone practicing modern aesthetic dentistry, or, frankly, for anyone who just wants to understand the science behind a beautiful, balanced smile.
It really is. This whole transition is about replacing, let's say, clinical subjectivity with verifiable geometry. We are moving from relying on a skilled artistic eye alone.
Which is so variable.
So variable. And we're moving towards relying on mathematical certainty. It's all about ensuring reproducible excellence in every single case.
Okay, let's unpack this journey. Let's start right at those geometric fundamentals. We have to begin where any successful design begins, and that's with references. In the pursuit of what our sources call the aesthetic effect, you have to set these definitive horizontal and vertical lines.
You have to. It's the absolute foundation of this whole smart design concept. It's the framework that lets us move beyond just, opinion.
Right, I think this looks good.
Exactly. Think of these references as the coordinate system for the face. Without them, any restorative work, it doesn't matter how perfectly you craft a single tooth, it's going to look disconnected from the overall facial architecture.
It's just floating in space.
It is. These lines are objective anchors. They help us translate this abstract concept of beauty into something we can actually measure.
And the most critical vertical reference line, of course, has to be the midline. It's so central to balancing the entire smile.
Yeah.
But as we were looking into this, the evolution of the terminology is interesting. It shows a shift in how we even think about checking this alignment.
It really does. The language reflects a deeper commitment to precision. Historically, in early aesthetic talks, checking the midline was sometimes called the T effect, or TFT.
TFT, and what did that focus on?
It tended to focus primarily on the dental midline's relationship to the nose and the philtrum. That little groove above the lip. It was a more localized dental reference.
But a smile doesn't just exist below the nose. It lives in the whole face.
Precisely. And as aesthetic practices matured, practitioners realized that true harmony, it demands alignment with the broader facial structure. This is what led to the adoption of the term facial-T, or foul-T.
Foul-T.
The foul-T concept ensures the dental midline is perfectly aligned with the entire facial framework. It typically references a line you get by connecting the centers of the pupils and then projecting that down to the chin point. You're using the eyes and the lower face as your key landmarks.
So the goal is the same, achieve symmetry. But foul-T just gives you a better, more robust anatomical reference because it pulls in more of the face.
That's the crucial distinction. And the smart design methodology, it completely embraces this standardization, so it doesn't matter which term a clinician learned first. The core of the digital concept is to accurately catch the midline using these modern comprehensive standards.
So you ensure the setup is in optimal harmony with the whole face.
Right. This vertical axis is the essential first step. Everything else, all the other design elements, they pivot around this line.
Okay, so once that robust vertical line, the midline, guided by foul-T, is locked in, what specific visual cues do we then use to establish the horizontal reference lines? The ones we need for a complete aesthetic diagnosis.
Well, the horizontal reference is really dominated by the pupillary line.
Running right through the pupils.
Or through the center of both pupils. This line is the benchmark for the horizontal plane. It defines whether the smile plane and the biting edges of the teeth are correctly leveled. If the teeth aren't parallel to that pupillary line, the smile is just going to look tilted.
Even if the midline is perfect.
Even if it's dead on, it just feels off.
That makes perfect sense. I mean, the eyes are our natural horizon line when we look at someone. So what other references do we need to build this diagnostic map?
We also have to assess the upper jaw reference line
Hmm.
that determines the vertical placement of the teeth relative to the lips and face, and it influences how much tooth and gum you see when someone smiles. And beyond those, the really comprehensive diagnosis, it requires evaluating the three-dimensional relationship of everything, the dental structure, the facial bone, capturing these complex relationships between left and right, front and back.
These are the detailed spatial coordinates the software is actually going to use.
They are.
And you mentioned that just cataloging all of these specific visual cues, these three-dimensional key points, it can add up to over 40 distinct data points.
At a minimum, yeah. You need those specific coordinates to precisely define the position and orientation of the teeth, the gingiva, the bone all relative to the face.
And in the pre-digital era, I imagine capturing and relating all 40 of those points manually was.
Oh, it was incredibly time-consuming and so prone to human error. That's why clinical success was so heavily dependent on the individual practitioner's experience, their, feel for it.
The digital tools just automate that mapping process.
Exactly. It guarantees an objective positioning every time.
Now, this brings us to one of the most classic principles in all of facial aesthetics, the rule of proportion. The gold standard everyone always talks about is the 1.1.1 ratio for vertical facial height.
Yes, the 1.21-to-1 ratio. That's dividing the face into equal upper, mid, and lower thirds. It's really the bedrock of classical beauty theory. It's all about aiming for a holistic balance.
But here's where it gets interesting, where clinical observation seems to diverge a little from the pure theory. You pointed out a fascinating observation among high-level designers. While 1.1.1 is the rule, the mid-face, so the area from the brows to the base of the nose, is often seen as being, quote, slightly higher or longer in reality.
It is, yeah.
So why does that happen? Does that mean the classical rule is flawed?
It doesn't mean it's flawed, but it suggests that our perception of beauty involves a kind of weighting. The mid-face has the greatest density of visual information. You have the eyes, which are the focal point, the cheekbones, the nose.
Right, it's where we look first.
It is. And when that section is well developed, it visually dominates the other two sections. So what you often find is that in profiles considered highly attractive, the mid-face is subtly longer. Maybe you're looking at a 0.9 to 1.1-to-1 ratio.
And our brain doesn't see that as an imbalance.
No, the brain interprets it as vitality or maybe a youthful aesthetic. It's perceived as harmony, even though it's not strictly equal.
So a great designer isn't ignoring the rule, but they're applying it with this critical understanding of visual psychology and anatomical norms.
Precisely. The classical rules, they establish the necessary framework. You need the symmetry, the parallelism, the proportional goals. The brilliance of smart design is that it captures these classical rules and then it allows the clinician to make these tiny, fine-tuned adjustments, like that slight lengthening of the mid-face, while making sure the overall geometric harmony is still intact.
The technology enforces the rules, which then allows the artistry to happen inside a measurable boundary.
That's a great way to put it.
So technology hasn't replaced the aesthetic rules at all. It's just given us the most precise way possible to actually execute them.
Absolutely. The first step is always diagnosis, catching those 40-plus reference points. The second step, which I think we should get into now, is using software to translate that diagnosis into a tangible, visualized design. It makes the formerly difficult task of aesthetic planning, well, extremely simple. Let's dive into that digital revolution then. Before these tools, getting that perfect alignment of the faulty, the pupillary line, and the proportions, it meant a dentist had to rely almost entirely on their accumulated wisdom.
And manual mock-ups. Lots of wax.
Right. But now you say that with the software, this incredibly complex process has become extremely simple.
The simplification is the real game changer. It's because the software takes over all the heavy lifting of the geometric calculation. Previously, those high aesthetic standards, they were really only achievable by a select few masters.
The ones who had the experience to mentally synthesize all those variables at once.
Exactly. Now, the necessary precision is just built into the algorithm. The software basically makes it available to a much wider range of practitioners, and that drastically reduces clinical variability and the need for decades of trial and error.
So how does this digital simulation actually work? I know it starts with a specific input photo. Can you break down what that photo has to capture?
Yeah, the photo needs to capture the full facial context, but, and this is critical, it needs to show the dentition with absolute clarity. This means the patient's mouth has to be physically open or retracted.
like with those plastic cheek retractors.
Yes, exactly. The sources mention it specifically. You have to fully expose the teeth, the gingiva, and all the surrounding soft tissue while still seeing the key facial landmarks like the pupils and the chin. That comprehensive capture is vital.
And once that photo is in the system, the software performs its main function, which is the overlay.
The overlay is the core functional breakthrough. The software lets the designer literally draw the ideal smile, the perfect tooth size, shape, and alignment, all based on those fidelity references we talked about. And then it accurately superimposes that design sketch right onto the patient's real facial photograph.
So it's a precise digital mock-up. You're basically pasting the ideal smile onto their actual face.
That's exactly what it is.
This visual confirmation must be so powerful for communicating with patients. But I imagine it's the interactive adjustment that gives it real clinical power. How easy is it to make those hands-on digital adjustments?
They're designed to be highly intuitive. As a user, you can just digitally drag, adjust, widen, or lengthen the teeth or the gum structures right there on the screen.
Wow.
Yeah.
Yeah.
If the initial design shows a little discrepancy, say a lateral incisor looks a bit too narrow, the designer can digitally pull that boundary out to meet the ideal proportional requirement, which is already defined by the software's grid. This allows for incredibly precise customization that respects all the classical geometric rules at the same time.
And the most important clinical value here has to be the pre-treatment simulation. This moves the process from being just a cool visual tool to a core part of your detailed preparation planning.
It's absolutely essential for preparation. We can simulate the exact aesthetic correction needed, the prepare part, as the source calls it. This means the clinician knows, before they even pick up a handpiece, the exact proposed outline of the final tooth structure.
And exactly how much enamel to remove.
Exactly. And the target location for the gum line. It just eliminates the uncertainty that plagued traditional prep methods. It translates the aesthetic sketch into a measurable clinical blueprint.
This methodology feels like it's becoming a global standard. You highlighted a few key institutions and systems that are really driving this aesthetic movement.
Oh, this is not isolated to one country. It's become a global language for digital aesthetic planning. We have to acknowledge institutions like NYU, New York University. They've done massive work in integrating these digital workflows into high-level education and research. They're really defining the next generation of aesthetic standards.
And you also mentioned the H-Human design system, which came out of Brazil.
Yes. Brazil has always been a leader in high-end cosmetic dentistry, and systems like H-Human design really reflect that expertise. They put a lot of emphasis on integrating personality and emotion into the geometric design, making sure the aesthetic plan really fits the individual.
So it's not just a one-size-fits-all smile.
Not at all. And the fact that so many high-level practitioners, including the one we referred to as and the founders of these systems themselves, are all actively using and promoting this type of software, it just confirms that this is the accepted standard for top-tier aesthetic work around the world.
For any dental professionals listening who might be interested in adopting this, what's the accessibility like? You mentioned that, well, there's a ton of information online. Actually buying it can be a bit opaque.
Yeah, that's a practical reality. You can find dozens of courses and demos online, but these are highly specialized clinical planning tools. They aren't sold like, consumer software.
You can't just download it from an app store.
No, not at all. They often require specialized training and integration support. You typically need to get them through specific local vendors, like the one mentioned, right top, who specialize in digital dental equipment. They can make sure the software is correctly calibrated and integrated with your existing scanning and milling tech.
But the investment provides a crucial tool for that pre-treatment simulation.
And that pays dividends in accuracy and, just as importantly, in patient confidence.
This ensures a seamless connection between the design concept and the eventual production. But, as we've talked about, an aesthetically pleasing sketch is one thing. Making it biologically safe and surgically achievable is another. And that needs hard anatomical data, which brings us to the fusion phase.
This is where we move from the purely visual artistry of smart design to the hard science of predictable clinical execution. If we just stop at the photo overlay, all we know is the ideal surface geometry.
What it should look like on the outside.
Right. But to actually modify the teeth or the gums, we need precise spatial data. We need to know the subsurface reality of the patient's anatomy.
So the photo tells us what looks good, but the scan tells us what is possible and, crucially, how to get there safely. This is where advanced scanning technology like CBCT comes in.
Absolutely. The advanced imaging we use, whether we call it a C-scan or more formally cone beam computed tomography, CBCT, it provides three-dimensional volumetric data
Of the bone, the roots.
of the bone, the root structure, all the supporting tissues. This data is the bridge between that digital sketch and the operating theater.
In actual clinical practice, how is this integration handled? You mentioned a specific workflow, the G-SMILE design process. What does that involve with the C-scan data?
The G-SMILE process, as a structured protocol, it dictates that the aesthetic plan from the smart design must be fused with the CBCT data. The CBCT essentially provides the anatomical coordinates. So, for instance, if the smart design suggests the gum line needs to be raised by 2 millimeters to get the perfect tooth length,
Okay.
the CBCT tells us precisely where the underlying alveolar bone is located relative to that target.
And why is that bone location so critical? Why can't we just, push the gums up 2 millimeters?
Because you can't violate the biological width. That's the necessary 3-millimeter space between the top of the bone and the gum margin that's required for healthy tissue attachment.
Ah.
If you push the gum line up 2 millimeters without adjusting the underlying bone, you compress that biological width.
Wow.
And that leads to chronic inflammation, recession, and eventually the failure of the whole restoration.
So the G-SMILE process uses the C-scan to find that bone level.
Exactly. It makes sure that if we change the aesthetic margin of the gum, we know exactly how much bone reshaping or osseous reduction is required to safely maintain that biological width.
This integration creates what you call the definitive formula for predictability. Let's break down how these different data points come together to create a measurable surgical plan.
Okay, so the calculation for precision, it really involves the convergence of three critical data sets.
Number one.
First, you have the smart design requirements. That's the aesthetic goal. This tells us the ideal final dimensions. For example, we need 10 millimeters of crown length.
Okay, that's the target.
Second, you have the known gingival and bone level information. This is the anatomical reality from the C-scan. It might show that the current bone level is 8 millimeters from the current tooth margin, but our ideal aesthetic margin is 2 millimeters higher than where the gum is now.
Got it.
And third, the fusion of data. This is the calculation. The system overlays the aesthetic plan onto the anatomical map, and it generates a surgical guide that specifies exactly how much bone reduction is needed to achieve that 10 millimeter length while preserving the biological width.
So combining the aesthetic ideal with the anatomical constraint lets the clinician know precisely how much to cut to get that beautiful, calculated final result.
That is the definition of can be predicted. This level of planning takes all the ambiguity out of these complex aesthetic and periodontal procedures. We are not guessing anymore. We're executing a pre-calculated mathematical plan.
I really want to emphasize the contrast here with the old model. Historically, a dentist just relied on their experience to judge how much soft tissue or bone to remove.
And that reliance on experience was the source of all the variability. In the old paradigm, a really experienced practitioner might have a good idea, a good feeling for it, but there was no template or guide ensuring millimeter-level precision.
And if the dentist was inexperienced.
The risk of error, poor healing, or aesthetic failure went up exponentially. The whole process was subjective, it was operator-dependent, and it was inherently difficult to reproduce.
But this new paradigm is entirely objective.
It is. Everything can now be calculated. Because the smart design quantified the aesthetic goal and the C-scan quantified the anatomical starting point, the necessary modification is just reduced to a simple, repeatable calculation.
So the computer has effectively replaced the clinical guesswork.
Guesswork and estimation are gone. It's been replaced with precise, objective data. And that ensures the result is reproducible and predictable across every case and every practitioner who uses the system.
And this certainty, I assume, allows for a seamless transition from the digital blueprint to the final physical restoration. How does the process conclude from the simulated plan to actual production?
That's the final advantage, closing the loop. Once the pre-treatment simulation and that calculated surgical guide are finalized and approved, the post-treatment result, the final crowns, veneers, whatever it is, can be fabricated with extreme precision.
The digital plan just feeds right into the manufacturing.
Right into the CAD/CAM milling machine or the 3D printer. This ensures that the final physical restoration matches the calculated aesthetic result you saw on the screen exactly. This integration guarantees that the plan actually equals the reality.
This complete system, then, from defining those classical aesthetic principles to applying the digital tools and then fusing them with hard physical data from a C-scan.
Yeah.
It really does represent a revolution in achieving highly precise and predictable clinical outcomes.
It's the highest standard of care we can offer. It's evidence-based aesthetics.
Well, this deep dive has certainly shown us the profound impact of smart design. It's formalized these classical aesthetic rules, turned them into objective data points, and then combined them with advanced scanning to ensure predictable, beautiful results.
It's a fantastic example of technology facilitating rather than replacing great dentistry. The tools just make these really complex concepts executable with simplicity and with certainty.
And that leads perfectly into our final open-ended question for you to consider. Now that we can use calculation and software to predict aesthetic results with millimeter precision, even dictating exactly how much bone or tooth structure to modify, do you believe the subjective artistic eye of the dentist is becoming less important?
Or is that artistry simply shifting its focus, maybe to a different, higher level of customization and adaptation, all working within the constraints of perfect geometric and anatomical planning?
Thank you for tuning in to Dentist Coffee Time. Bye-bye.